Welcome to Deep Dive Ortho. We're here to unpack complex orthopedic challenges and give you those critical insights. Today, we're looking into something really quite rare, but potentially devastating for shoulder function, an atraumatic rupture of the deltoid muscle happening alongside a chronic massive rotator cuff tear. It's also quite a confluence of pathologies, isn't it? It needs careful understanding. And guiding us through this is Professor Mo Imam. Now, a deltoid rupture itself, it's not exactly common garden variety stuff, but an atraumatic one. How should we really be thinking about this specific type of injury?
Well, hello. Yes, you're right. Deltoid rupture is rare, and it can cause really significant problems with arm function. We often think of it perhaps following surgery, maybe an old open rotator cuff repair, or sometimes after a reverse shoulder replacement where the deltoid's been, partially released for access. Other things like steroid injections or trauma obviously can play a role. But this atraumatic type, that's the real outlier. A tear without any obvious injury, no fall, no heavy lift. And the numbers back this up. Studies looking at shoulder MRIs find it in maybe 0.3%, sometimes even less, perhaps 0.04% of cases. It's incredibly uncommon.
0.04%. That's really striking. So if it's not trauma, what's actually going on underneath? What's the theory behind how a chronic cuff tear could sort of lead to the deltoid just giving way spontaneously?
Yes, there's a pretty compelling hypothesis. Essentially, with a massive chronic cuff tear, you lose those balance forces that normally keep the humeral head centered. So when the deltoid fires, instead of rotating the arm smoothly, it can pull the humeral head upward superiorly.
Right, it rides high.
Exactly. And this high-riding humeral head can then impinge or sort of repeatedly knock against the deltoid's origin on the underside of the acromia. Over time, this chronic mechanical irritation, this impingement, is thought to cause degeneration within the muscle fibers, weakening them.
Ah, so it's a slow degenerative process precipitated by the bad mechanics from the cuff tear.
Precisely. The altered biomechanics ultimately make the deltoid vulnerable to rupturing, even without a specific traumatic event. We've seen this theory supported by the few cases described.
Okay, that makes sense mechanically. Let's bring this to life with that specific case study you mentioned, the 73-year-old woman. 3-year history of a massive cuff tear, then this sudden atraumatic deltoid rupture. How did she actually present? What did you see?
Certainly. So this lady had been managing her chronic massive cuff tear for some years.
Yeah.
MRI had shown significant atrophy of the supraspinatus, infraspinatus, and subscapularis. She actually had been offered a reverse shoulder replacement previously, but declined as her function was still what she considered reasonable for her needs. Then about 9 days before she came to see us this time, she experienced a really acute onset of new symptoms: sudden weakness, increased pain, some visible bruising, and a noticeable change in the shape of her shoulder.
And crucially, no injury.
Absolutely crucial. She explicitly denied any fall, any specific lifting incident, any trauma whatsoever. On examination, you could feel a definite defect, a gap, just distal to the anterolateral part of the acromion. And you could feel the retracted deltoid muscle belly bunched up further down the arm. That palpable defect, incidentally, is actually quite rare itself, may be seen in less than 10% of deltoid ruptures overall.
So that was a strong clinical sign.
A very strong sign. We got a new MRI, which confirmed the ongoing massive cuff tear, but also clearly showed the anterior head of the deltoid had ruptured and retracted distally. And then intraoperatively, we discovered the middle deltoid head was also involved in the rupture.
Right, so you've got the deltoid rupture and the underlying irreparable cuff tear. That must make treatment decisions incredibly tricky. What were the options on the table, and what was the thinking behind the final approach?
It really does raise that difficult question. What's the best strategy for such a rare and functionally compromising combination? We talked through everything with her. Non-operative management was one option. Another was just repairing the deltoid. Or the third option was doing a combined procedure, repairing the deltoid, and performing a reverse total shoulder arthroplasty at the same time.
And she opted for.
She chose the isolated deltoid repair. A major factor in that decision was the acute nature of the deltoid injury itself, and also the understanding that good deltoid function is absolutely critical for a reverse replacement to work well.
You need the engine.
Exactly. You generally wouldn't proceed with a reverse if the deltoid isn't intact and functional, or at least repairable to a good state. So preserving or restoring that was the priority.
Okay, so walk us through the repair itself. How did you approach it surgically?
We used a superior approach, an incision running from the coracoid process over the top of the acromion. Interestingly, when we first got down, the actual tear wasn't immediately obvious because the overlying fascia was still intact.
Ah, hiding the problem.
A little bit, yes. Once we incised that fascia and cleared out the hematoma, the full picture emerged. We confirmed the massive, irreparable cuff tear, supraspinatus, infraspinatus subscapularis, all gone, and then we identified the avulsed anterior and middle heads of the deltoid, which were quite significantly retracted. For the repair, we used strong, absorbable fiber tape sutures. We passed these through the muscle tissue using a specific technique called a Mason-Allen configuration. It provides a very secure grip on the tissue. Then these sutures were passed through drill holes in the acromion and tied over a small 3-hole metal plate placed on the top surface of the acromion. This creates a very stable fixation point.
Right, anchoring it back down securely.
Exactly. We performed the repair with the arm held in some abduction to reduce the tension, and we checked that even when we brought the arm back down to the side, fully adducted, there wasn't excessive stress on the repair site.
And the recovery. Post-op rehab, especially with the pandemic complicating things.
Yes, the postoperative phase was a bit unusual because of COVID. She was immobilized in a splint, holding the arm at about 30 degrees of abduction for the first 2 weeks. Then she transitioned to a standard sling. We planned for passive range of motion exercises to start at 4 weeks and active motion from 8 weeks. But her access to formal supervised physiotherapy was limited to about the first 9 weeks. After that, she continued with the home exercise program.
And the outcome at 1 year. How did she do considering the limited formal rehab and the underlying cuff issue?
At her 1-year follow-up, which was done via telemedicine, she reported her overall shoulder function was, perhaps surprisingly, grossly similar to her pre-rupture state.
That's significant given the added injury.
It is. She had minimal pain, really only experiencing discomfort at the very end of her range of motion, or if she did something particularly strenuous. Passively, we could get her shoulder flexion to about 100 degrees and external rotation at the side to 30 degrees. Actively, she could lift her arm forward to 60 degrees and actively externally rotate to 20 degrees.
So functional, but still limitations from the cuff tear, presumably.
Yes, absolutely. You have to be realistic. The pre-existing massive cuff tear will inherently limit the potential for optimal function after just a deltoid repair. However, looking at the broader picture, systematic reviews looking at deltoid ruptures in general suggest that direct repair, like we did, or sometimes reconstructions using tendon transfers, are worthwhile treatments. These can be done with or without a reverse replacement, depending on the case. And generally, they lead to significant improvements in pain and achieve functional gains, often getting active elevation and abduction above 90 degrees.
So for clinicians listening, what's the main takeaway message when faced with a patient who has a known chronic cuff tear and then presents with this sudden deterioration?
I think the key message is maintain a high index of suspicion for deltoid injury. Rotator cuff tears are common, and we see them all the time. But if that patient suddenly develops acute pain, a new deformity, perhaps bruising, or a really quite sudden, unexplained drop in their shoulder function, you must consider the deltoid.
Don't just assume it's the cuff tear getting worse.
Exactly.
Sure.
Think deltoid. Because identifying it early is crucial. It allows for the possibility of surgical repair. And while the underlying cuff tear might mean you won't restore perfect pre-injury level function, repairing the deltoid can still make a very significant difference to their pain levels and their overall functional capacity for daily life. It's about optimizing what's possible in a difficult situation.
That's a really vital point and incredibly insightful discussion into a complex and rare problem. Understanding these nuances is just so important for anyone managing shoulder pathology. If you found this deep dive valuable, we'd really appreciate it if you could take a moment to rate and share the show, and maybe something to ponder as you go about your day. With technology moving so fast, how might things like advanced imaging or perhaps even AI-driven diagnostic tools help us pick up these rare combined injuries even earlier in the future? Thank you for joining us on Deep Dive Ortho.